we should get started. Nice to see you all here at an evening event. And I'm delighted to welcome Maureen Lewis, here on my right, advisor to the Development Economics Department at the World Bank, formerly a fellow of the Center for Global Development in the US, and also formerly chief economist of the Human Development Network at the World Bank. You're welcome, Maureen. And on my left, Professor Alan Winters, who's currently chief economist at DFID and also a professor of economics at the University of Sussex. I'm Alison Evans, and I'm here from ODI. This event is looking at a paper that Maureen and colleagues have prepared on governance and accountability in healthcare delivery. Maureen's going to give us a presentation for about 30 minutes or so, and then Alan's going to give some reflections and maybe raise some further questions, which I hope we'll be able to follow up in discussion. I mean, I think one of the interesting things about this paper, and it's a very timely one in many ways, is that, you know, I'm very aware that the debate about health sector performance can at times get very polarized between very vociferous debates about the kind of input end of the health sector. So it's all about more nurses, more doctors, more of everything, more drugs. Or there's a big debate about how do we read the outcome side, which is what are the right outcome measures and how do we assess from an outcome perspective whether or not those inputs are delivering. But there's a big piece in the middle, if you like, the black box of health system delivery, which at times I think we tend to skirt over, or we don't spend enough time thinking about, or we don't understand enough about. And I think this paper very much takes us into that black box. Starts to talk about why health system delivery in and of itself is an area in which we need to focus attention, but also to try and understand the problems of health system delivery and some metrics for establishing what would good performance in this area look like. And Maureen's going to lead us through a discussion based on the paper, and then Alan's going to give us some responses. Why don't I pass over to you,
okay.
Maureen?
Thank you.
You take the...
Stand so I can see everyone. Okay. Oops. Thank you. Okay, this has became an issue because we were looking at governance and anti-corruption, and it seemed that that really wasn't doing what we needed to do to make things happen, to be able to answer the kinds of things that Alison laid out. And healthcare, as you know, is quite complicated. And I think that we've also tried to make it very simple. And I think one of the things we've learned in the United States in the past year is that it's not very simple, it's very hard to understand, and it's very hard to measure. And the developing countries are not alone. But what I'm going to do is talk a little bit about why governance is an issue. I'm going to also talk about what makes good institutions, which is the underlying purpose of institutions, right? And how do we measure performance and get into the black box that Alison mentioned. So why is governance an issue in healthcare? Part of it is the health systems issue, the black box issue, the fact that we're delivering care and we don't know what's happening. We're spending a lot of time worrying about whether or not we have inputs. We are worrying about whether or not there are enough staff. And while these are very important, if we can't stop there. And I think much of the debate everywhere has really been focused on those issues. So what about healthcare delivery? So that's part of why this becomes important. And because we don't have data, we don't have evidence, we have usually a very gross measure like infant mortality. And the problem with infant mortality is that in poor countries, increases in income, increases in mothers' education makes a very big difference in the infant mortality rate. It may or may not have anything to do with healthcare. So it leads to some very difficult abilities to be able to track performance and know what's going on in the money that's being spent on health. So we don't have performance measures. That's the first thing. The second thing is we have poor quality services and we don't have good information, but what we've tried to do in this paper is develop some kinds of indicators that tell us whether or not things are working very well. And they're somewhat crude, but they're very telling. One is on absenteeism. It's something that we're finding increasingly. We haven't measured it very much, but we've got some indicators now. We've got some methodologies for getting it. The inefficiency. There's a lot of mismanagement. Professional managers are very rare in developing countries, even in middle-income countries. But this is becoming apparent as a problem in many of them. There's an issue of corruption. There is no question. There is in developed countries as well. But again, this has not been something that's well documented, and where it has been documented, it's a cause for concern. And then there are very few incentives. One of the problems that we find in many healthcare systems in many countries is that there isn't a merit-based system, one. Two, there are very few promotions in public systems. In some countries, you get one promotion. And once you've got that promotion, what incentive is there to do well? For the person who doesn't show up, you get paid the same amount for the person who comes in every day and provides the full care of services that is expected. So that creates some very poor incentives. And finally, and I think most importantly, is there's very little accountability. And if I take a typical country, you often have the central government hiring physicians and nurses, deploying them, and then also sending out managers. But those managers don't have either the skills, or even if they do, often do not have the authority to be able to deploy staff, to move staff, to, if not to fire them, but at least to move them to do something where it's less damaging. And so it's very hard to have any accountability of those staff, because who they answer to are not their supervisors. And their supervisors, it's not clear whether they can't be fired either, and their behavior sometimes is also problematic. So you have this lack of accountability because it's not clear who people are meant to report to. So what we say in this paper is we really need to focus on a few things. One is standards, and we don't talk about that directly, but we do deal with it in some of the evidence at the end. Secondly, we need some basic information on performance. How is the system performing? Not so much the outcomes, because we have a hard time attributing, but how is it performing? How is it working? We need something on incentives. What are the incentives in the system? Can we tweak them? Can we make things work better by having better incentives? And then how do we deal with accountability? And that's, I think, the definition from the Oxford Economic Dictionary is the officials are called to account and to answer for responsibilities and conduct. And that is something that is missing in most systems. And corruption is something I think is much easier to define and much easier to see when it's there. So what this small schematic does is basically go over this issue of, here you have stakeholders, here you have service delivery, you have provider performance. Well, these two things aren't necessarily related. The beneficiaries and the stakeholders have a hard time influencing providers because they don't answer to the beneficiaries. Local government sometimes has some say, but not always. Sometimes the Ministry of Health does. Sometimes both of them do, which makes it confusing and leads to problems in terms of performance, in terms of both measurement, in terms of what happens. So this is just trying to provide something visual in terms of what we're trying to talk about in the relationships. So when we've tried to put together some of these measures of performance, and what we're doing is trying to do something that's affordable, that does not require new surveys and new work on a large scale, but develop some simple tools and some piggybacking of existing surveys. So we're talking about simple qualitative and quantitative surveys, pilots, management and rethinking management, and coming up with some new ideas. And I won't be able to go over them, but a lot of the back of the paper really talks about some of the innovation that has been done in a number of countries, sometimes with the World Bank support, sometimes with DFID support, sometimes on their own. But there's quite a lot. There's quite a lot there. Okay, and so what kind of indicators are we talking about? We're talking about budget. We're talking about individual providers. We're talking about health facilities themselves. We're talking about informal payments. This is something that sort of doesn't fit in some ways, but it's a very telling indicator, because we're finding in a number of countries that policies are not having the effect that we expected that they would, and we've discovered that part of the reason that the incentives are distorted by the fact that people are paying under the table, and so that government levers are not as strong. And then finally, corruption. And I have a list here of what we have from the paper that is more detailed. And that gives you, whoops, pardon me. And what that does is it gives you sort of the kinds of things we're talking about. So in budget, it's the budget process, it's the budget leakages, it's payroll irregularities, in-kind supply leakages. And there are ways to measure it. And we talk about those because those are readily available. Leakages, we've done a lot of work on public expenditure tracking and things of that look at public funds. That allows you to tell whether something is working or not, and sometimes it becomes very interesting. We have a case in Benin where all of the accounts were on spreadsheets, and they knew where all of the drugs were, and it was really quite impressive. And somebody went to look at the warehouses. They were empty because it was basically a way to sort of show and get rid of the people who were asking questions. So you sort of have to know what's happening on the ground. So I will talk about some of these as I go through, but I think I don't really have time to go through them. But it gives you a sense of what we're talking about. So what I'll do is I'll take the first one on the budgeting issue, and that is the public expenditure and financial analysis are surveys that are done in something on the order of 130 countries now, funded by all of the donors together. And what they do is they look at how well budget is executed. And I've got an example here of three things. One is the aggregate expenditure outturn. So how much of their spending were they actually able to spend? The effectiveness of payroll controls, and the availability of information on resources received by service delivery units. So these are just three of the things that are collected under PIFA is what it's called. And what you see here are 5 countries and how they differ across these three indicators and across each other. And it tells you something about how well things are working on just this very basic function of, is the money getting there? Is it being spent as expected? Is payroll under control? Because payroll well, I'll talk about later in a minute. The public expenditure tracking surveys. There haven't been very many in health. There have been partial ones, and I couldn't compare them here. But these are 3 that were done for health, and basically this was the leakage rate. That doesn't mean that they were stolen. All that means is that they didn't reach the unit of delivery. So this is not so difficult to do, but it gives you, again, it's an indicator of performance. Pharmaceutical procurement. This is a big area of a big problem. WHO is spending a lot of time. DFID has been working with them through a program called META, and we have worked with them at the World Bank as well, because we find some disturbing results. One, WHO estimates that 25% of drugs in low-income countries are counterfeit or substandard. We have 30% of that is true in China. We have a lot of procurement problems. Again, they've been identified, and in some places we've been doing some increasing work trying to make that less problematic and and more transparent. But one of the things that I think was most disturbing for me in looking at this evidence is the experience of Costa Rica, where they were looking at drug theft in hospitals and asked patients and nurses, and they came up with 32% of users who were aware of some theft of drugs. So this is clearly an issue. It's not surprising because even in developed countries, drugs tend to be locked up in all points of service. But it's an issue because that means there are no drugs available, and there's a reason. If we go to the issue of absenteeism of providers, because that's really where we're talking about this. This is a graph of a lot of different kinds of studies that have done work that have looked at absenteeism, and some of that is quite shocking, like in Bangladesh here. So it's about 75% absenteeism, and some of these were done by surprise visit. Some of them were done as time and motion studies, but in various ways, and they're all, but they all show some disturbing problems of absenteeism. So one of the things that we tried to look at were what kinds of things are there in the literature that tell us what kinds of interventions would help to address this. One of the things that is quite surprising is that higher salaries don't seem to have a very much of an effect. It doesn't make people show up, and it doesn't keep them on the job, and it doesn't keep them on task. So that's one. Rewards and discipline of performance does seem to matter quite a lot. There have been some very interesting studies in Africa, also in Mexico, and there's a third country I'm forgetting, where they've looked at performance rewards for providers and how well that's worked. But the disciplining has also mattered a lot, and they found that the quality of service also goes up when you can discipline poor performers. Payment system reform is a link of performance and pay. This is a big issue right now. There is a lot of experimentation going on, and I'll talk about that again in a moment. And the last thing here is contracting out. There's some fascinating work that the World Bank has been supporting in Central America, contracting out to NGOs and to local communities to put together healthcare, and they've been doing some evaluations, and they've been quite satisfied with it. But they've also been providing oversight and watching it. But it seems to have worked very well in isolated communities. So on facility performance, well, that's the third category. So there's a lack, again, of performance incentives and of managerial authority, as I mentioned. So there's a very interesting study in Brazil that I will maybe I'll just explain it here and give you the data later. This program, they decided that what they would do is hire a manager from the outside, give them a new hospital in a poor favela area of São Paulo. They did 12 of these hospitals. And they allowed that manager to have the budget that everybody else had, to have the staff that he found acceptable. He could move out any staff, public physician that he wanted to, or nurse. So they were public employees, but they worked for him and they had to answer to him. And they all happened to be men, but that's not necessarily going to continue. But I can use him in this context as a result. So what they found, and they made them put data on the web every single month of what was happening in those hospitals. And then the World Bank did an evaluation at their request of those 12 hospitals and 12 hospitals that were essentially the same. And the results are quite impressive. But the real key here is that there was authority and there were consequences for the manager, because if he, after 6 months, had not met this, he was fired. So there was a clear discipline, and he was well paid, and he would get bonuses at the end of the year. The payment system is critical. How do you pay hospitals? This is a big issue in even developed countries, but increasingly we're paying on the basis of a bundle of services. And that's starting to take hold. But there's some other issues that can be, there's some other ways of paying that reward good performance and that discipline bad performance that seem to work well and need some more, that need additional attention. So what happens with medical supplies? I won't go into this for very deeply, but what this shows is the differential in prices paid for the same materials, these 4 materials, across hospitals in 4 countries. So in Bolivia, you have a great variation in the prices that hospitals paid. In the other countries, you have a lot less. And all of these other countries have had oversight bodies that have been providing guidance and also providing ranges of prices that were acceptable. Now I can't make this work. Okay. Okay, this is the Brazilian hospital. So what I'll show you is that the average length of stay dropped for the contracted out public hospitals. The technical efficiency was greater for all services. The expenditure was lower than it was in the other hospitals. You also had mortality rates that were lower. You had surgical mortality rates that were lower. And you also had infection rates that were lower. That's not shown on this chart. But the difference after 6 months of performance was quite dramatic. And it's been consistent across all of the hospitals. So what were the key features? One was the autonomous management. One were the incentives for efficiency, for cost containment, for equity. The managers of the hospital have all said, you give me a public hospital, I will spend less money than they do and do a better job. But they can also make sure that they have staff that they can hire and get rid of. They don't fire them, they just get rid of them. They move them into another part of the system. Now, that may not be the answer for everything, but it does mean that human resource management may play a role. Strategic purchasing, they bought in bulk. They didn't rely on the national government, but they did some procurement as pooling. They contract monitoring and enforcement. Again, the enforcement of contracts was a major change, made a big difference in costs. They had lots of information. And this goes back to this whole issue of metrics and being able to manage performance. They were required to manage performance, and as a result, they had data. And they had to use it, and they did use it because they were, not only because they were required to, because they realized that that allowed them to run the hospital better. And finally, they were accountable. And this goes back to the being able to hire and move staff. Fire is not the right word. And that, so that there was some accountability. So on informal payments, the definition is charges for health services or supplies that are meant to be free. There have been a lot of qualitative studies that have been conducted by a number of people that have been, one of the most well-known was done in India by, I can't remember her name right now, but did a whole series of studies on inequality and public services, and found that health was one of the most common services to have informal charges. And we've just done some other work in the World Bank, and health has come up as one of the sectors that is most frequently charged for illegally. So it seems to be an issue. And what you see here, this is for Southern Africa, and you have to make sure, no, I'm sorry, this is for Eastern Europe and Central Asia. So, and some of the data are a little bit dated, but I think that what's relevant was how high some of these have been, and what that means for equity of care, what that means for being able to have incentives to encourage good performance. Because you can see it visually. You go into a hospital, there are lots of doctors and there are lots of nurses and there are no patients, and it doesn't really make sense why. But that's why. In Africa, the metric is different, so it's not anywhere near as high as what you saw on the other chart. But, and these are more recent. They're not as well, they're not as thoroughly done. But I think what's interesting is that they have turned up some high frequency in a number of countries. So, whoops, did I forget? Okay, and one of the things that I think is important about I forgot that there wasn't a narrative afterwards. But one of the things about informal payments is that a few countries have actually tried to do something about it. And what they've discovered is that the thing that works best is putting in formal charges. And that those formal charges then get rid of the corruption that comes with the informal payments. And there are only a few sites in which research has been done, but that's pretty much what they found. Then on the issue of corruption, you know, all of the work that's been done by Danny Kaufman and Cray and all of these, and those studies and the studies of Freedom House are all done on perceptions. So perceptions are a very big part of it, partly because people don't voluntarily talk about it. So we've had to get data indirectly. And these surveys, the governance and anti-corruption diagnostic surveys that the bank has done in a number of countries, they started in Eastern Europe and Central Asia and has expanded. This is the percent of households perceiving corruption in the health sector. And it's somewhere between 20 and 50% roughly, with only not all countries having answered the question. But it is rather concerning. And then there was another study that was done in a bunch of hospitals in Latin America, and they also found a high degree of perceived corruption within the hospital. And some countries have actually done some very interesting things with that. For example, with procurement, they've gone to e-procurement where everything is on the web. And that's actually an increasingly common way of doing it for national government procurement. And that helps to get away from some of the corruption in that area where it's quite common. But it sort of riddles the system in where corruption is a problem at multiple levels. And one of the areas is on the purchasing of positions. I mean, except for Zambia, where it was 50% of the public officials who were asked. It's about what 10 to 20%, depending on the country, felt that there was job purchasing in the country. Because again, the job purchasing also links to informal payments. And it's been South Asia and Eastern Europe and Central Asia where it's really been shown to be a big issue. and that getting health care for free isn't really happening, even if that's government policy. So in summary, let me just touch on a few things. On incentives and accountability in particular, and one of the things that is become very much appealing, has been very appealing, and the UK has had an experience with it, is the pay for performance. Sometimes it doesn't work on an individual basis because it becomes part of what people get paid normally. And so one of the things that has emerged from the literature on developing countries is that where it seems to work best is where it's connected to hospitals. The hospitals get something as well as the individual providers. That seems to work better. There's another, in addition to the Brazil study, there's an interesting Argentine province hospital program that we developed with the Argentinian government because primary care was not reaching poor women in urban centers. What they did was they set up a program where the physicians got paid for treating the number of women who came in to see them for prenatal care, and then they were also responsible for them over the course of their pregnancy and for delivery. And at delivery, there were a number of indicators of the infant, among them the APGAR score, that would tell you how the woman had been treated during pregnancy. And this has been a highly successful program. I didn't bring the data on this, but you see a big increase in utilization and a big increase in attention, and you have a drop in infant mortality, which was one of their big objectives because infant mortality in poor communities was quite high. So it's been quite successful, and it was designed about 5 years ago, and it's still going on. It's quite a good program. In the Philippines, they did some impact evaluations and also found that where they could reward both hospitals and physicians, they got much better performance, and they could measure the performance in those hospitals. So those two, and that's been funded by a number of different people, and it was actually done largely by the Philippine government with involvement of international researchers. The contracting out and holding the directors accountable, as in the Sao Paulo example, but also this example that I mentioned in Central America. Community control and oversight. This has been a big issue in trying to improve good governance and in reducing corruption. It's very hard in health. It's hard to hold somebody accountable who has a lot more education and status than you do. You go to poor rural communities, that link becomes much more difficult. But there are some communities who have tried to do this, and I think the verdict is still out. But I think that it's worked better in primary education than we see in health, but that doesn't mean it can't work. But it's certainly on the agenda and something that's concerning a lot of people. And then the issue of addressing corruption, of making it unacceptable, and of having the data to be able to track it. And some countries have done that in terms of being able to, doing qualitative and quantitative surveys to do it. So going forward, so I think one message from this is that good governance matters because it is a reflection of how the institution performs. So that's key. We need to consider the incentive structure, the accountability and the enforcement of rules, and those examples that I gave I think are important. And we need indicators, and the indicators that I showed briefly before I think are the kinds of things we need to build on. We don't have them for every country. As you saw, there was a different set of countries for every set of data that I presented because we don't have anything consistent. And until we have something consistent, we can't compare across countries. What we can do is say, we've got a performance problem, and these kinds of indicators can help us get a better handle on the health system and how it's performing, and then we can try to go and worry about how we do things with respect to incentive structures and accountability. So I think these indicators become very important, and I think it's worthy of a debate and more work to hone them and to get better indicators. This is sort of what's available and how can we think about it in the short term. But I think this is key. And we need benchmark countries. We need to know how countries are doing because at the moment we don't have anything to compare. In fact, the World Health Organization in 2000 ranked health systems, and there are by country, and there are countries that still don't want to deal with WHO on the basis of that because it's so arbitrary, and they tried to be scientific, but it's very hard. So we need more evidence. we need to get some agreed indicators, and we need to get data for those indicators. And I think if we have that, we will be on the road to helping to have health systems mean something in terms of performance, and not just general outcome measures, but in truly how the system is doing, how it's delivering, and how it's functioning. So thank you very much.
Thank you very much indeed.